Good morning, Mr. Rituparna.
Good morning, sir.
Mr. Rituparna, can you make me a co-host, please?
Sure. Right now doing, sir.
Okay, and you have the first video and the last video to be played. You have?
Yes, sir. I'm just sharing my screen for your kind
Sure,
perusal.
not a problem.
So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation USA chapter. The focus of today's session is echocardiography in heart transplantation. To start with today's Sunday TE session, I would like to present before you a short welcome video.
Good morning to everyone present here. I am Dr. Murlidhar from Bangalore speaking to you. Today we have the Sunday TE webinar. The title of the topic is Heart Failure and Echocardiography with special emphasis on heart transplantation. And before I actually hand it over to our experts, Dr. Chintan Seth and Dr. Vijay Shetty, I would like to request you to put your questions on the chat box, and comments also can be made on the chat box. We will address all the questions within the time limits of this seminar after the talk. So with that, I again welcome you and request Dr. Chintan Seth, who is a leading cardiac anesthesiologist in Gujarat. He has done over 50 heart transplantations, and I think he's a good moderator for this session. So I will ask him to take over and introduce the speaker and go ahead with the talk. Thank you so much.
Good morning all. I welcome all of you on this Sunday morning. And Dr. Vijay Shetty doesn't require any introduction. We all know him very well. He is very renowned in the field of cardiac anesthesia. So today we will lucky to have talk from him on echocardiography in heart transplantation. So as you all know, echocardiography has essential role in the heart transplant, not only during heart transplant, but even pre-heart transplant to optimize the heart failure patient when he is on the waiting list, and even post-heart transplant also. So almost every day we do the echo post-heart transplant. So now we'll get enlightened from Dr. Vijay Shetty on this talk. So I welcome Dr. Vijay Shetty to deliver a talk on this.
Thank you, Dr. Chintan. Can you hear me?
Yes,
sir.
we can hear you.
All right.
Please carry.
Okay. Thank you so much, Dr. Murli sir, for this kind invite, and Chintan for being there. I am especially thankful that Chintan is here because I got a couple of disclosures. One is that though we had a very good experience with cardiac transplant for the last couple of years, I have not been doing it, but I still have fond memories of the time that we spent doing our 120 odd transplants in the city of Mumbai. The second is that if you've been a regular attendee of these TE sessions, you will probably not learn anything new. But at the same time, this is a integration of what are all experiences that we have, and you might get as you go about your journey in cardiac transplant. And I'm happy to share my experiences. And later on, when the question and answers come, I'm sure that me and Chintan together, we will try and address any issues or any challenges or any understandings that we may have to propagate. So with that, I bring you greetings from Fortis Hospital, Mumbai, which is one of the major hospitals in this part of the city. And I have the pleasure of running two simultaneous teams. One is a cardiac team, which looks after adult and pediatric cardiac. The pediatric cardiac is a separate entity, and also a general anesthesia team. We run about 10 OTs in this modest-sized hospital. Today is a happy Father's Day, and I wish all the fathers in this and who is listening a happy Father's Day. But for me, another disclosure I have to make is that all that I learned from about EE and my initiation into it and my development to it is because of Dr. Murli and his hardworking team at the Narayana Hidayah, from the very initial days when I remember the first decade of the century when we attended this first time that the TE conference. It was a novel thing then, and thanks to his untiring efforts, I think many like me have learned the TE and development. So for me, he's the father of TE. So happy Father's Day to you too, sir. And I'm sure all of you are raring to attend the August session. This also gave me an opportunity to visit my time. And for those who have never been into a cardiac transplant, I think that is very rare now because almost all the teams are now gearing up to do it or have done it already. This is how the first transplant looked after it chemo bypass. You can see all the monitoring is present. We have the continuous cardiac output monitoring. We have the bispectral index, the NIRS, and this is the closure. Everybody's happy that the surgery went off well. There's a cardiologist in the background, and this is my team with my fellows. So you can see Mahendra, Ilyas, Vikesh, Dr. Shivaji, who's from Narayana. He's our pediatric cardiac anesthetist, Dr. Prajakta, who's now a consultant. All of them hovering around the TE machine to look into the machine and see how the heart is doing. Because we all know that we can look at the heart from the surface, but like it was said in the initial part of the introductory video, that the echo is absolutely essential in this. And like Chintan said, right from the beginning that the patient gets posted or listed or even first time is looked into, the echo is the what sets the tone along with the symptoms that the patient has. Has the patient an irreversible cardiac issue, which can be sorted out by the gold standard of treatment, which is the transplant? So in spite of having LVATs, permanent LVATs and durable VATs, which are having a very good efficacy in many countries, that is a go-to therapy. One, because of lack of therapy, and secondly, because there is no immune modulation required. There is no immunotherapy required in those patients. And often, these VATs are used as a bridge to transplant. So we have all those issues coming in. So as you start doing a cardiac transplant, you realize that it's not only about the replacing the heart, but all those things that happen prior to the transplant to optimize the recipient. Second, all those things that you do after the cardiac transplant is done to make sure that the heart is not rejected and it's maintained at a very good level for years to come. So that are the twin challenges that are there for the cardiac team. In between lies our role. When the cardiac transplant patient comes in, recipient, you work him up and first decide his eligibility for transplant. But most often they will have already a decision made about that the transplant is essential. You need to find out things for which the patient might not survive the surgery, or the risk benefit ratio indicates that not doing a transplant and probably doing a VAD might be the better way out. Now, coming to the transesophageal echo in heart transplantation, there are multiple articles that you can find. These are two of them only, but there are multiple transplantation, multiple articles that are written. Please note that around only 4,500 to 5,000 cases are done every year. It's not that thousands and thousands of cases are done. These are the number of transplants that are done in the entire world. And there are few centers only which are doing more than 30 or 50 transplants a year, which you can say a decent or a good busy practice, in which a repeated investment in the same kind of in the same kind of protocols will make you understand the caveats, the risks and the risks that are run, and how to pick up a problem. That having been said, I can very easily say that any dedicated team who's doing their routine cardiac practice diligently, having good monitoring systems and having a way of moving things in a very clean and sterile manner, having good protocols, will be able to take up the challenge of heart transplant if they were to indulge in it. So for this is just the what is different in the from the other surgeries is what we do surgically, and therefore I thought that I'll just talk a couple of slides upon the surgical techniques of heart transplant. So in this is the biatrial technique. You can see here, if you can see my cursor, this is how the old heart will get out, and this is what will remain. That's just the cuff of the atrium will remain here, and in the biatrial transplant, in the biatrial, you will find that the SVC and the IVC both are remaining as they are, and the RA and the LA are going to be anastomosed. So in the biatrial, you have two atrial anastomosis, and then the two large vessels, and then the surgery is done. So that's only a 4. You can see that the right atrium is open and the IVC is kept intact. Okay, this is the. However, it is most likely, and this is what we do nowadays. We only do the bicaval technique. In the bicaval technique, there is an additional one more anastomosis that comes in, because we are excising the entire right atrium, and therefore the SVC is going to go to the SVC here, the IVC of the new heart is going to the IVC here, and but the first anastomosis that is done in either technique is the left atrial anastomosis, which is the most posterior anastomosis, and this is what is done, and very diligent this needs to be done, because it usually tends to bleed from there, and once it bleeds from there, it's very difficult to control it. So the surgeon spends the maximum time in doing a proper LA to LA anastomosis. And because of this, why is this more popular? One, because it preserves the entire integrity of the atrium, which is important because the number of arrhythmias, requirement of pacemakers go down drastically, and more importantly, the incidence of tricuspid regurgitation is very, very minimal. Or even if it were to occur, it usually settles within the next 6 months to 1 year, and that is huge implications for the survival and the general condition of the patient. Therefore, by and large, your surgeon will choose the bicaval technique, and that is what you will be able to see, that there are suture, that is anastomosis of the SVC, the IVC, the right atrium, left atrium, and the great vessels. So this is another picture which tries to tell you about the anastomosis that can happen. So one more thing is that if since we are already running against the ischemia time, we may decide to do the SVC, anastomosis like SVC or some part of the PA on a beating heart after the clamp is out, because it's very essential that the heart gets reperfused within 4 hours from the time that it was clamped in the donor. So with this understanding, we also need to understand that there are other challenges that come in. For example, there might be previous sternotomy for say bypass or some other ball replacement has been done. Now everything is failed and the heart is now only having 10% DF with severe MR and so on. They might be on LVAD or might be on ECMO. So there is additional time and additional bleeding, meaning these patients will be more unstable, and therefore the TE also will have a very important role. There is a de-airing which is absolutely essential after the completion of all the anastomosis, and we'll come to that. There are existing pulmonary and extracardiac issues which needs to be looked into, we need to be vigilant about, and see how it impacts the function of the heart. Vasoplasia is not uncommon, though we are not seeing so much such high incidence nowadays. Understanding of immunology is important, pacing, support, pharmaceutical support, all these are important, and additional monitor like you saw, NRS, CCO. In this background, the anesthetist also has a role to look at the TE. So what we are doing even if you have 2 or 3 people, there will be one. What I tend to do is that one person looking after the pharma and the hemodynamic management, one person looking at the TE and providing the information, so that there is delineation about what each person is going to do, and that is a good way forward to see that your personnel are used properly. At the same time, there is no overlap of functions. And that is one thing we need to look after. All in all, at all times, for a properly chosen heart, the right heart is the one which is always at risk. And that is the one which will be the center of attraction or the center of the focus as whenever we do a heart transplant. So peri-op echo, like Chintan said, donor selection is one thing that I'm not going to talk about because everybody knows what a good heart looks like. When you go to a donor, and most often what happens if you go to a peripheral center, which is a donor center, but it may not have a transesophageal echo even. So most of our assessments happen with the transthoracic. In states like Maharashtra, where going or traveling with the echo machine is absolutely very, very, very difficult. But in states like Tamil Nadu, it is very common for the team to go with the TE probe and the TE unit. So they get a TE done and a proper assessment of the heart is done because you need to rule out even the smallest things. It might not be a contraindication for the transplant, but it will be something that you need to be addressing. For example, ASD or something like a mitral valve repair might be necessary at points in time. You might miss out a thrombus or some dissections in the ascending aorta. So these kind of things need to be properly assessed because it is once the heart is harvested and your patient goes in bypass, the recipient goes in bypass, it is usually an irreversible step, and then we cannot do anything about it. The second thing is that the whenever the patient first comes in, the pre-op recipient comes, then the transthoracic echo is our go-to. It's very rarely that we need to do a transesophageal echo for a recipient to see his eligibility for a transplant. By and large, it is the transthoracic which will be telling us that, okay, this is what happens. And the transthoracic echo is very easily done, and all anesthetists again are becoming good at it. And for a transplant anesthetist, it is very important that you be good at a transthoracic echo of getting pictures and assessing the functional, because it's going to be a continuous process, and we need to be continuously assessing the patient ourselves to see that what is happening to the heart, how is it deteriorated, how is it improved. Often the patients go home on a home meldinone, so that is also important. Pre-CPP assessment is done, a post-CPP assessment is done, we'll talk about it, echo in the ICU and a follow-up. So the pre-operative assessment, like I said, the transthoracic, it looks at all these things: LV function, RV function, the IVC diameter collapsibility, thrombus pressures, PVR can also be calculated by formulas. Also, while doing that, make sure as anesthetist you do a scout scan of the neck and the femoral vessels. But this is very important because you might find that there is a thrombus, and then your mind already starts thinking about what alternate sites are there from where I need to be able to put the lines. Some of the patients have got renal dysfunction, which means that we need to plan a large renal dialysis catheter. So all this kind of planning can be done prior rather than on the day of the surgery. And these are all dynamic and changing, ever changing. Therefore, our inputs and doing the scout scan or the focus scan ourselves might be a good idea as far as possible, so that whenever the patient comes for any other reason, we can just have a chat with him. That builds a rapport with the patient as well. And our echo, doing our, because many of the times the anesthetists manage the post-operative part for the transplant patient. So it becomes very easy to then develop a rapport as well as do the continuous transthoracic echos in the post-operative. Now, these are some of the pictures that you might find in that. You find a big LV, you find dilated right ventricle as well. You can see the LV is hardly moving. You also find that there is bilateral dilatation, and this is what I was talking about, the clot in the IVC or the femoral veins. All those things might be done because the blood flow in many of these organs is in hearts is quite sluggish, and in spite of having undergoing anticoagulant agents, many of them develop thrombus and clots, and they might develop later on. The first time they may not be evident, but later on they might be evident, or sometimes the other way around, you find some clots, but then they also tend to go off with the proper management. So on the D day, when the patient comes for a transplant, pre-operative, what are we trying to do? We are not trying to discover anything new. We just reconfirm that the diagnosis, that what we see, what we had seen all these days, it is the same diagnosis. We look at the LV volume and the contractility. The goal here is not to now this organ is going to go to the bin. What we need to do in those 2 or 3 hours that precede the bypass, please remember that we have to get the heart to work the best it can, even overdrive it, so that the end organ like a kidney, brain, lungs, those are protected well, because they have to take the brunt of the insult when the patient comes off bypass and the subsequent days. Therefore, having a good map, a good cardiac output is very important. And this you can drive the heart a little bit to the extreme, because you know that when the new heart comes, this is going to go on bypass and we are going to be out of it. And we also have ready to go on bypass if there was a cardiac failure at that point in time. The T guides in the optimum LV filling, because you already know the heart. You have also we go with the measured things about what the hemodynamic monitoring is showing as well as what the T is showing, bring those two together and then decide how to give a preload. And most of these patients at the time of inductions would be on a vasopressor already as a preparation as well as a prophylactic one to just optimize the map as well as the filling pressures. So hemodynamic adjustment is done, and all these times we will be using the trans-esophageal echo intraoperatively to see that. You will find a restrictive pattern, but that is to be expected. So this we can see in patient who has got biventricular dysfunction, very big heart, and this is the kind of picture that you see. This is a restrictive cardiomyopathy in which you can see biatrial dilatation, a well-functioning RV and LV, but they are small in size. Here also there will be severe restrictive pattern if you were to put the. Sometimes you get surprises. This is one of our heart-lung patients, Samish reminded me of this for this. Because this is a large coronary sinus, and he's got a left SVC draining into the coronary sinus. And you can understand the implications when you're going to resect out the heart and you have one more vessel to have a cannula in. This throws into difficulties about how to manage the drainage and how to figure out a plan to make sure that this now will be draining into the new heart. So the surgeon has to figure out an access to do this. And this was missed out in the previous echo. So fortunately, we were able to warn the surgeon in advance, so they were able to pick it up and correct it. So a role of we should not trivialize the role of the T in the pre-bypass period. It is very, very important. The other important thing in the pre-operative pre-CVB echo is to clot. Like I said, this clot and thrombosis, you can find this thrombus in the LA appendage. There might be a there might be a thrombus like here. Exactly this patient, if somebody were to put in a LVAD, you can see this is exactly where this comes in. And this is important because this is so far nestled in the heart. It is not causing any harm. But when the surgeon tries to remove the heart and he tries to dissect out the heart, those manipulations might cause these thrombi to migrate out into the aorta and cause, you might have a perfect transplant, but the patient wakes up with a stroke. And these are the things that need to be warned. And this patient would probably go on an early bypass and then a resection rather than doing the dissections around the heart before the patient goes on bypass. So, and this is again another thing where whether there are proper thrombus lying in the right atrium. So these are the warning things that thing can go very wrong in spite of a perfect surgery, and these are warning signs that we can provide to the surgeon to be careful the way they manipulate the heart. Now about the right heart, like this heart is again, like I said, going to be resected. This is the recipient heart, the original heart. When you look at these hearts, what is the idea that you get is, if I get this heart is obviously very big heart, dilated cardiomyopathy, but you can see how well the RV is moving. This sort of indicates that we have optimized this patient well, because the crux of managing the RV is to make sure that the PA pressure and the PVR, which would already be enhanced or increased because of the failing heart, the LA pressures, the pulmonary venous congestion, and so on. Post-capillary pulmonary hypertension already exists in these patients. But that has been managed quite well. Therefore, the heart, in spite of being a poor heart, the RV is working well. And by and large, you will find very acceptable PA pressures and PVR readings in the pre-bypass readings of these patients. On the contrary, if you have a heart like this with the RV hardly moving, and you might find PA pressure which is low because of the poor hypo-functioning RV. But at the same time, it sort of warns you that you need to get the nitric oxide, the milrinone, and all the strategies that you are taught about the pulmonary vascular resistance management and the pulmonary pressure management on board to see that the new heart at least has a chance to do well as far as the right ventricle is concerned. So I hope I gave you an idea about what is to be done in the management. So finally, the old heart comes out, and this I like to show for two things. One, that in spite of having an EF of 10%, this heart is still beating once one is disconnected from everything else, trying to show you the value of resilience of this heart, something that we need to imbibe in our own lives as well. So now we also examine the aorta in the donor and the recipient, also for aorta for atheromas, pleural effusions. So pleural effusions are almost always existent in sicker patients, and the magnitude of is usually not known, but the T is a very easy way of managing, of diagnosing pleural effusions, and it will be very good on our part to get that drained early on to allow the lungs to function well, and in the post-op we do another suction and make sure that the effusions are not there, especially when we come off bypass. LVAD explantation can also be guided with this with the T. It also helps you to float the PA catheter. As you know, there is a lot of tricuspid regurgitation and pulmonary valve regurgitation often, which does not allow the PA to go across. I for one I'm always insisting on having the PA readings before we go on bypass, so that we have some values to go by as to what we are doing, because the patient has been evaluated long time back usually, and we don't have very fresh values of a properly collected PA sample. It also guides the CPV cannula placement and any undetected anomalies like I already spoke to you about. This is a atheromas, and this is something like a catheter which was passed for the ECMO. This was not having any bearing on the, but it just tries to tell you that how the TE is essential whenever we are going at for the post CPV. We are looking at the de-airing. Like the de-airing is very essential because at the end of a long surgery, because you're waiting for 2 hours, then they put another 2 hours on this. So, and they're very much keen to get it off before the 4 hours are out. But for me, what I think it is wise to make sure that your heart is properly de-aired. You take extra minutes there because that is invaluable. The left ventricular dysfunction we'll monitor. By and large, the left ventricle function in a properly selected heart and a properly managed heart in which aplasia has been given properly, it has been transported well, the temperature has, the cold chain has been maintained. Usually it is good. RV ventricle function, we'll speak about it a little bit more detail. How are the walls doing? How is the left atrial anastomosis? How are the vascular anastomosis doing? I told you about in the beginning of the talk about how the vascular structures are anastomosis and so on. And everything that we have done, the anastomosis that has been done has to be evaluated in the subsequent. This is the idea about the de-airing. Like I said, venting and de-airing are very important. You need to make sure the LV apex, the LA, the pulmonary veins, everything is devoid of air, and it usually takes a few minutes to get this on. Often we give carbon dioxide as a continuous insufflation into the field, which seems to be helping as far as the proper de-airing is concerned. But you need to be making sure this is done properly, because if air were to go, or a lot of air were to go in the system, that is dangerous, of course, for all the organs, but especially to the right coronary artery. If it goes, then it is going to cause RV dysfunction. And as we know that the RV is the one which we are protecting at all times, and just this careless mistake can lead to RV dysfunction, leading to a prolonged bypass support, or sometimes even RV. Pulmonary catheter flotation is another thing that the thing helps in, and we found that it was very useful because we can when the heart has been transected, the pulmonary catheter is withdrawn into the PA sheath, and then the bypass on bypass, subsequently the surgeon goes and resects out the recipient heart. After the surgery is done and the new heart is implanted, now our role is to again float the catheter back. Sometimes that becomes a problem because TR is still present, and the heart sometimes has difficulty in going. The catheter has some difficulty in going to the pulmonary artery. So we see that here we can dilate it into the tricuspid wall through a modified view, and then see that ensure its path as it goes up the infundibulum into the pulmonary artery. Getting obviously at the same time we are looking at the waveforms as well. So what happens in the LV? What we see is that the LV has increased septal and posterior wall thickness because of the preservation strategies. There is a lot of edema in the LV, which takes some time to resolve. You'll find that the thickness is much more than what it normally was when you saw it first as a donor. There is increased LV mass. Often because of the RV dysfunction, there is flattening, as you see here. The septum is not moving and tends to be D-shaped or flattened. The heart also sits in an abnormal way. You have to remember that this is a heart which maybe it had a dilated cardiomyopathy. It's a huge pericardium. The donor heart that comes in is usually smaller, though it might be from appropriately chosen donor, but it's quite smaller, and now it will sit in the pericardium. So the usual pericardial restraint or the support that pericardium is important for ventricular interdependence is lost, and therefore the heart will be lying in a pretty much in a free space, sort of speak, suspended by the IVCs and the great SVC, IVC, and the great vessels. So you might need to have a little modified views to get a proper picture, but it is usually not so much of a struggle. So as you start feeling the heart and you see the it coming off, you get an idea about what the LV was, because you already have the pictures and the videos of what your associates sent when you had gone to see the heart, a transthoracic or a transesophageal, and you have a fair idea of what to expect. And usually you have to wait till the LV comes to the normal or what it was in the preoperative in the donor. And these are the ways that you are already aware how to do the EDA and the endostolic and systolic area and find out about the ejection fraction. But I can tell you clearly that what as cardiac anesthetist is, when we do it, we don't do too much of this technical or the actual numbers unless we really want to do it and we have time to do it. It is usually done later on. But what we are interested in is that is this LV developing an adequate map, an adequate cardiac output, at the back of not having a very high CVP and RV which is looking good. So that is the whole crux of the problem. But the TE helps essentially in seeing whatever interventions we are doing for the PA pressures, for the PVR, for the RV, as for the blood HB is concerned, and as we are reducing the support, it gives a very good idea about how the LV is recovering. So you'll be forgiven for thinking this is the old recipient heart. Actually, this is the new heart which has gone to the patient. You can see how massively the RV is dilated and how poorly the LV is moving. And once the ECMO was put, you can see that RV function has at least recovered. This patient went on ECMO for a few days and then he made a full recovery. For making these kind of decisions in a timely manner, the TE is priceless, along with all the other human data that we are otherwise also collecting. This is another example you can see as we are coming off. You can see how the LV is not yet recovered, and subsequently we see the LV is recovered. This is another patient who's on ECMO weaning, and you can see the LV function recover. So not only for the cardiac issues during the transplant, but anybody goes on a mechanical circulatory support device, and then subsequently after a few days when we are weaning him off, TE has a very important role along with the continuous hemodynamic data to give us confidence that this patient is able to sustain the ECMO weaning. Diastolic function, I'll not talk about too much. I think it's must be discussed multiple times, but it is obviously because of multiple reasons that the LV dysfunction, diastolic dysfunction will be present in majority of the recipients. Now the RV assessment is for post-transplant 50% complications and early deaths high percentage because of RV dysfunction. RV is the one which is always has to be monitored and always to be at the back of your mind, because LV will always by and large do well. Now, two indices like RV, fractional area change, and TAPSIA are integral to the RV management, as multiple articles will tell you about RV function monitoring, along with all these rest of the parameters, including RV wall motion, RV size, RV position. Now you have the work index, you have the strain patterns of the RV, and so on. If we don't indulge in so much high-end monitoring or decision making, it becomes quite clear in the as we go and see this patient, as we see multiple patients, this RV is able to manage its load, it's going to do well. Say, for example, if it's a small lady and you put in a very robust heart from big patient, in spite of the PVR being high, you might be able to get across this high PVR and high PA because the heart is quite robust. If it's the other way around, you take a heart from a small lady and put it into a well-built male. This heart, by and large, will not succeed in the first attempt. You will have to give it support. And by and large, we don't choose such hearts because we know that we are running against a wall in expecting the small right ventricle to take up the load of a patient with a very high PVR. So this is how we do in the four chamber, the fractional area change, and this is the mild, moderate, and severe RV dysfunction. If fractional area change is less than 18% is severe RVD. But obviously this is all again technical things that endocardial body identification is not taken, RVOT is not taken. But this is the best thing that we have at present, which can be easily done to show or document in quantitatively as to how is the right ventricle doing. TAPSE, on the other hand, if you can get a good transgastric view, RV focus view, and you can put a cursor across like this, we might get a good tissue doctor to see the TAPSE, and anything you see that it is in a good height, two figures around 15 or plus, you will be assured that it is doing quite well. For anybody interested in the interpret assessment of RV, this is a very good article which tells about how to look after all the walls of the RV. Primarily, again, like I said, eyeballing itself will be sufficient in most of the times, but you want to do a more detailed technical analysis as to what is failing, if there's anything global about it, or is it is something that is affecting only one wall, then you might have to do a proper RV study to see whether it is the inferior wall, anterior wall, lateral wall, or the infundibular wall, which is not acting up well. In the transgastric RV basal view, by and large, we get to see all the walls. These are some of the RV views that we spoke about in the article. This is the RV inflow outflow view. We can you can see that you get a good assessment of the PA also can be done. I'll show that in a subsequent video. So this again, we can see this RV seems to be disconnecting and not moving well. Lateral free wall, and you can see after some time, you can see how the RV is now robust. The free wall is quite supple and it is moving well. Here again, the RV is not sliding on the pericardium, and subsequently you can see even if you don't have a TAPSE, you can eyeball and see how well this lateral annulus is sliding on the pericardium. That gives you a sort of idea as to the longitudinal shortening of the RV is happening. That is what we are interested in. Is the RV shortening longitudinally? and that can be eyeballed out, and the subsequent hemodynamic pressures and etc. also will help you make a decision. As for the monitoring, the management tree of the RV is, as for diagnosis is concerned, you can see here again that TAPSE is, as well as the free wall, the fractional area short is change is the important things that are looked at into as far as the RV dysfunction is concerned. One of the things that is usually gets hidden or is not looked at very actively by most, especially when you're a youngster and coming into the scene, is the septum. The septum can give you a lot of idea about how the heart is doing, the IAS as well as the IVS. And anytime there is a D shaping, you need to pick it up early and see if it's a diastolic or a systolic D shaping. D shaping is when the right ventricle, this is how the normal ventricle functions, the globular LV and something elliptoid RV is there. When this septum starts going to the left hand side and becomes like a D like this, and this happens in diastole or it happens in systole, will tell you about whether there is a volume overload or whether there is a pressure overload. So the eccentricity index is easily calculated when you just pick up the minor axis, which is parallel to the interventricular septum, and then measure it, and then take it to and divide it by the D2, which is the axis which is perpendicular to the minor axis. As you can understand, if there is a D shaping, this septum will move to the left, thereby reducing the D2, and therefore the ratio of D1 to D2, which is usually 1, will become much more than 1. And it is very important to see if that eccentricity index is more than 1. That means there is D shaping, and this you can measure it in systole and diastole to see whether it is a volume or a pressure overload. The left-sided anastomosis, like I said, is done first, and it's the most posterior anastomosis. And because it is a very edematous tissue and a very dense tissue, when the anastomosis is done, you will usually see anastomotic ridges, suture sites, which appear very prominently in the echo, and they should not be thought of as the thrombus. And they can be seen as very bright shadows. You can see them here, both of them. And these are normally expected in a post-transplant patient. This is another view of the ridge in the 3D. It's more of the same. So the length of the anastomosis of the vessels and the is very important. Surgeon takes a lot of care to see that there is a good approximation of the sizes, so that there is no stenosis and there is no torsion. But sometimes it may happen that because you got a very small IVC, or there is a huge long length of the large vessel available, it might lead to malalignment and torsion. And this may not be very much evident when the chest is open, but it might happen after the chest is closed. So even if the chest is closed, you need to have a proper assessment, especially if there's hemodynamic compromise, to see whether if the PA is having excellent flow. You can see in the transgastric flow, you can see the PA flow, which is nice and blue, showing that there is no turbulence. And you can also do the color Doppler to see the velocity. And if it's in 1.5 usually meters per second, is usually be okay. So kinking and torsion and stenosis is important. Why is it important also is because not only for the cardiac, but also because if there have been cases where the revision of the PA anastomosis has to be done, because the kinking, even if the 25% narrowing, it has led to significant dysfunction of the right ventricle, which again we know is the hero of this entire surgery. And therefore redoing the surgery is a good decision, rather than expecting the RV to not only deal with the PVR and the PA, but also an anatomic narrowing in his path. All walls are properly assessed. Like I said, tricuspid regurgitation is a given. But if you have a good map, the tricuspid regurgitation just needs to be watched. If your tricuspid annulus was wide or big in the beginning, then some form of repair has to be done in the donor heart in situ before giving the patient this heart. Or we can just watch it carefully and see that if the hemodynamic are maintained, then even a moderate tricuspid regurgitation can be expected, because we know with our experience, with time the edema goes down, the RV becomes supple, and the TR also disappears totally, or becomes very mild within the first 6 to 8 months after good supportive therapy. Again, you look at the mitral wall, because sometimes with this edematous myocardium in a borderline ventricular hypertrophy case, you might have a SAM-like picture with a LVOT showing some turbulence. There is also a flame-like MR indicating time. This is, you can see a late peaking dagger pattern of the flow. So this will all indicate that there is a SAM which is happening, which can be managed like we manage our normal scan. SAMs. SVC, IVC anastomosis also can be done with this focused views, deep transgastric views, where the SVC and the IVC are properly seen, aligned. And this is a good view to see. You can see that both the SVC and IVC are, we have put in the sectors, and we are seeing that the color is quite nice and smooth. Again, PFOs, all of us know, left to right shunt to right to left shunt, leading to overload or to hypoxia. This is one of our patients who had this. In the ICU, what happens because of the entire stickings and the sometimes we keep the in unstable patient, we keep the echo in place for a few hours post-op when we want to do it rather than putting it. Please remember, these are all coagulopathic patients in whom we can't keep on putting probes in and out, and we keep it for a few hours just to see how it is doing the immediate post-op. But if the heart is doing quite well, there's no need to keep the echo probe, and it is usually removed. We avoid the TE unless there's profound hemodynamic instability for which we don't have an easy window in the transthoracic. And we try to do subcostals, and we try to see the hearts through a transhepatic view also in the transthoracic, using the transthoracic in the post-operative. Usually it tends to show some pictures about how the LV and the RV are doing, which is what we are all interested. This is just what is the role of TE on the cardiac transplantation. Like I said, there is nothing new here. Everything depends upon what your understanding of the operation is, and all that you've been taught in this about the TE will can be put into good use to detect something that was missed before, evaluate how the surgery went, how the response to surgery was as far as the RV and the LV are concerned, and later on to detect things like effusion, pericardial effusions, and the heart. So the markers of rejection, like there is a lot of interest in seeing whether we can detect the echo-based rejection. It is very difficult because there is increased LV mass and thickness in the initial days, and subsequently it goes down. However, if there is LV EF goes down more than 10% after it is recovered once, if there's new pericardial effusion, any regional wall motion abnormalities, restrictive filling patterns, in spite of optimum medical therapy, we usually it and your immune profile will come as showing markers for rejection. Then endomyocardial biopsy is usually required for these patients. TE in transplant is important because primary graft dysfunction is very important aspect of any transplant program. Primary graft dysfunction happens when the heart gets rejected in spite of, sorry, not rejected. The heart is having a dysfunction in spite of having done everything is been done optimally. It is because of poor myocardial protection or temperature variations and so on. Secondary graft dysfunction happens when it can be, the PGD can be a right-sided, left-sided, or a biventricular. Secondary graft dysfunction is because of excess blood transfusion, because of very high PVR, or there is a cause for which the graft is now dysfunctioning. Please remember, this is a coagulopathic patient, so we should not be doing repeated TE insertions. If a TE is in place, we don't use the same maneuvering or go about. Everybody has a go at it. That is not done. It is done by the person who has the most experience. It is done gently, and it is done with the care, because we don't want to have a complication in the patient's esophagus and the stomach. And I want to highlight this point because it's because we are seeing so many good pictures. Everybody we not have to repeatedly do the study. There has to be a reason why we are doing the TE, and that focus on getting or enabling that information is very, very important. Eyeballing can be done constantly just by keeping the probe in the esophageal view and having to do it. Please remember to tally it with invasive hemodynamic monitors, because TE alone cannot be the decision maker. It is to be done with, I think I told you that is 3 or 4 times in this session. Well, some issues are to be accepted. Like, for example, TR is accepted. There is no point looking at it again and again, because we know that it functionally is going to improve, and you have to accept it and expect it. This is immunocompromised patient. So having a good care for the TE is very important. Now, of late, I think the TE wipes are also available, and we need to make sure that these are properly sterilized. There's a properly cleaned probes which are going to be inserted in this patient, because after the course of immunosuppression, very immediately, patient runs the risk of even fungal infection. So we need to be very sure that these are all frail patients who have not been eating well. So we need to be very careful about these parts. The future is that a lot of work has been done about assessment of these hearts using global longitudinal strains, and RV patterns are also now, anesthetists are also interested in getting this, and we are expecting some publications in this coming from our part of the country as well. The second is that we have miniature TE probes. Now this will give you some focus, few views. I've not had experience with this, but this seems to very good. Like an ridership, just keep it in for the next 48 hours. It will give a few views and information about continuously monitoring a patient in whom otherwise views are not available. So in borderline patients, this might be a good idea. These are expensive, of course, but then these are very good things. So with this, I end my talk, and I thank you once again, Murli sir, and the entire team, Clarinet team also, for giving me this opportunity. Thank you so much.
Excellent talk by Dr. Vijay Shetty. He has covered almost all the points regarding not only with the echo, but even with the management of the heart transplant patient. I just need to add few points. So first of all, what he has mentioned that importance of learning transthoracic echo for any transplant anesthetist is really very important, because every day we have to do transthoracic echo post-operatively, and even pre-operatively also during optimization we have to do transthoracic. So we all must learn the transthoracic echo well. Second thing, pre-operatively clots are very important, as you mentioned, and these clots are common when patient has AICD or CRTD in the place. So many patients first they will be put on AICD from the left subclavian vein. Then subsequently patient undergoes CRTD on the right subclavian vein, and then both the subclavian veins are filled with the leads. There are very high chances of clots. So when these leads are in the place, we should be more careful and rule out the clots pre-operatively. Then pre-operatively, when patient is there in the waiting, like he has recipient has been called and we are waiting for the donor heart. So pre-operatively we check the transthoracic echo, and as he mentioned that many times PA pressures and everything has been changed, because we have evaluated this patient 3 to 4 or 6 months back, and now there is high PR or high TR or high PA pressures. In such patients, we would like to start low dose of Mildrin on pre-transplant only, so that will prepare the PVR for the donor heart. And we found that is very helpful, and even it will make more stability of the patient during induction also. So we can start pre-operative Mildrin if we find that there is high TR and high PA pressures. Then one more thing, the floating of PA catheter pre-transplant is sometimes very challenging, because this patient's RV is quite dilated, and many times it will not go because of severe TR also. And a few times doing this, they are more prone for arrhythmias, or there can be that even this myocardium is well stretched and it is thinned out. So there can be chances of cardiac perforation also. So one or twice you try. If PA is not going pre-transplant, just keep it into the sheath or into the SVC, and don't try to do much maneuver to float the PA, because anyway we know by TR we can see the PA pressures pre-transplant. Anyway we want to right heart cath also. So floating PA is definitely important if we can do it, but it's not mandatory. Many times we have not tried much to float it inside. Then our protocol is that when we first see the echo after the transplant, after the anastomosis, and when we are filling the heart, most of them, almost 90% of that, there will be RV-LV dysfunction, as is mentioned, because of edema and ischemia repulsion injury. So our dictum is we give 1/3 time of the rest of the ischemia time. Suppose ischemia time is 4 hours, we give 1 hour and 15-minute rest before we fill the heart, and that will give the good support of the heart to recover. RV dysfunction is almost, I can say, 80 to 90% of the patients post-transplant, we will find out RV dysfunction. Definitely you will get RV dysfunction. And TAPSE is almost lost in almost all the patients. So TAPSE as such value is not the predictor for the RV dysfunction, but trend is important. TAPSE will require, it may take even 3 to 6 months to recover the TAPSE. Sometimes even at 6 months when they come for follow-up, everything is fine, but still the TAPSE is like 12, 13 like that. So, and we found that the RV dysfunction, if there is more TR, septal position, underfilled LV, and LV is brisk, but it is underfilled with dilated IVC, high CVP, low PA pressures, that all will suggest the RV dysfunction. And generally RV dysfunction tend to happen after 24 hours, because initially the donor RV tried to overcome the high PVR, but over the time it will become tired. So initially you feel that RV was okay, everything was fine, patient is stable, and after 24 hours, suddenly you will say hypotension, there is high TR, CVP will be high, PA pressures will be low. So this RV dysfunction second to high PVR we'll find out on the generally after 24 hours. And yeah, so that's all.
Thank you, Chintan. Very good comments.
Thank you. Thank you so much, Vijay, for that excellent presentation. If you can unshare the screen, we can see
Sure.
each other better. Thank you so much. And I would like to thank you for saying that I'm like a father to you. Thank you so much. You have made my responsibility more now, and not that I need to. You are already doing very well. Thank you so much. I wish you all the best. The other thing is, I just wanted to correct one statement that we don't learn nothing new. This is not true, because every time I do this, I get some new information and I learn from this. So that is one. The other thing is about the floating PA catheter. The TE can also be used. Suppose the PA catheter is getting into the right atrial appendage or into the IVC, or it's not going in the proper direction, you can take use of the TE and direct the PA catheter by anti-clockwise or clockwise rotation as needed to be able to enter the right ventricle and then float into the PA. And there's one question on the chat box. Is it TAPSE is reliable in predicting RV dysfunction in post-cardiac surgery?
If I can take that, I think Chintan has already talked about it. And
Yes.
so the TAPSE is like since we do not have too many measures, look at the RV, and since the RV is very important, we should try and get the TAPSE for all our patients by using the transgastric views, like I mentioned, because
Yeah.
what the proper alignment we get in a transthoracic echo is not very easily possible in the transesophageal, number one. But we make it a point to just to try and get it, because when we keep on doing it, we get a hang of how to get it done. But I will not base all my management on the TAPSE. It is fundamentally a integration of all the information and then take a call. But if you find that TAPSE is good, by and large, it means that your RV is excellent, meaning you will not have any problem, at least for the next few hours, if you are not going to overload the patient, ensure a proper diuresis, and do not increase the PVR. So it sort of gives you sometimes you get very good robust hearts, and our duty is to make sure that they work the same way in the recipient. And if we find that the TAPSE is good and a high number of you get a TAPSE of 15 and 20, and the LV is moving, the RV is moving quite well, usually you are out of the woods, is what I wanted to indicate. So it might not be the sole or the only or the most important even, because like Chintan correctly said, the TAPSE remains low for quite a significant amount of time in most patients after the transplant or even after cardiac surgery. In an open heart with cardiac surgery, again, TAPSE is not supposed to be a very reliable parameter, but I think it is a good trending device. Yes.
So for RV assessment, as we all know, there are two motions. One is the longitudinal fiber motions, which we can measure by the TAPSE. Other is like bellows-like motion, that free wall moves towards the septum. So this TAPSE as absolute number is not much give us the value. Yeah, if it is good, then we are assured that RV is good, but low doesn't mean it's too low. RV dysfunction is very less. So this free wall motion we can assess by putting the M mode in the RV inflow outflow view. So if you do take the RV inflow outflow view and put the M mode, and you can see the motion of the RV free wall during systole and diastole. So if severe RV dysfunction, there will be almost no movement of the RV during RV free wall during the systole. And this is not mentioned, but I found this is very useful to assess the free wall function of the RV, and TAPSE will give us the longitudinal function of the RV.
That is true. That is true. Actually, in a report from the Journal of Cardiovascular Anesthesia, they mentioned that caution should be exercised when you're using TAPSE to evaluate the right heart function after cardiac surgery.
Yes.
So it may be inaccurate. That's what they mentioned. So you have to exercise caution, and as Chintan said, you go by trends rather than the absolute values. Vijay, the Sanjeevani, you want to say anything? You have done extensive work on this here.
Yes. Beautiful speech by Vijay. Today I really enjoyed it. And
Yes.
Even Chintan has made clarification on TAPSE, which is very important.
Yes.
I just wanted to ask Vijay, what are the common causes for RV volume or pressure overload in a relatively normal donor heart? Is it iatrogenic, like volume overload by giving more fluid or something like that?
Madam, actually this is a very important question. At the same time, it has got multiple answers. One, I think Chintan can also take a shot at this. But then what we find that in spite of our best planning, sometimes and best preservation, the most important person, I think for me, I used to go for the donor retrievals myself for quite a few years, because I always felt that how they retrieve the heart is important. How we optimize the heart in the donor there far away is very important. And having a nice supple heart, which has been properly exsanguinated before you clamp, is also very important. For example, you open up the venous chambers, let the blood out, and then you clamp. and you find that the LV is empty, and then you give the cardioplegia, that works out very well because it ensures a proper distribution of cardioplegia as well as a very small heart which can be properly pledged. And then transporting, having proper protocol without breaking the proper rules of how the heart is preserved is important. Sometimes ice is very, very cold, and you might the RV will take a hit. We find that in case the heart is a good donor, a robust donor, and a good recipient. What is a good recipient mean? Not his age and all. It depends on his PVR, pH, and how we have managed his. Even if it's elevated PVR, if we have managed to get it down by a continuous millinone, like we have strategies where we send the patient with a continuous millinone, and like Chintan said, start millinone before the surgery, and those kind of things to prepare the PA bed well. Usually, you'll not find any problem. But if the RV is showing signs of volume overload, then it has to be diuresed very quickly. Often, sometimes the bypass time is more. You might have had not proper management at bypass. So multiple things there can be air embolism into the right coronary. There might be a pulmonary artery might be a little bit of torsion or a little bit of constriction might be there, leading to a little bit of turbulence, but nothing much more. So all these things are what do you call aggregation of marginal gains, they say. Like similarly, there is aggregation of marginal problems which can lead to a major problem for the RV. Therefore, astute management is very, very important, and you're on the right track when you see your mapping improves, your CVP is not rising, your TRA is also stable, your sliding of the tricuspid lateral annulus is seen well. So these things like give you confidence that you are on the right path. And you please remember also, this is all happening when the patient is bleeding away. Surgeon is handling the heart again and again. It's at the end of a major bypass surgery in which a patient was already a sick, frail patient, and a lot of blood loss is still happening. We are collecting the volume, giving blood. We are deciding whether to give blood or no, whether to give the product. So all these things are all simultaneously happening. So I think this is a very chaotic, not chaotic, I would say, but a very happening time. And this needs to be negotiated very well with the anesthetist taking and the surgeon in combination, taking a good patient to the ICU, from where the subsequent things can happen.
Yeah, very, very nicely addressed. I think RV being a very delicate chamber, putting ice on it, that is a very valid point. I don't know whether you remember, surgeons used to put ice slush, so saline ice slush on heart previously. And then we used to suffer coming off bypass many times. So maybe that is a good point. Another important question I would like to ask is, do you do 3D RVEF? Because FSC and all those, I mean, it is a very dynamic situation,
yes,
or chaotic rather, but as an academic thing, or which is the most ideal thing one would do?
not in my experience, madam. We, I think, do a lot of other things, but 3D studies, unless we pick up something and we want to study it properly, then we do a 3D for that. But most of the information, we are okay with this kind of management that I spoke about. But maybe Chintan can talk about it, but we don't spend too much time in doing, like I said, high-end like stain and all those things
told
for
you,
at
it's
this
just an
situation.
academic. Yes.
We also don't do 3D assessment commonly, routinely we don't do it.
Okay.
Most of the time, PA pressures and CVP and 2D echo can give us the good idea. Anytime when we found PA is low, like PA pressures is like 25, 28, and CVP is like 18, 20, more than 15, and some RV dysfunction 2D echo, we know it's a RV dysfunction.
Okay. How much importance you give to TDI on right side? TDI.
Issue Doppler imaging. So for RV function, only S prime is important. So if S prime is less than 10, we can say it's RV dysfunction.
Because that is relatively quite sensitive. I mean, poor man's strain, one can name it. Another thing, Murlidhar, can I ask one more?
Yeah. We have 2 to 3 more minutes. Yes,
Okay,
you can do it.
Vijay had shown this dilated coronary sinus thing. In the initial videos of his heart, just can you go back to that? I just wanted, I mean, I didn't understand what did you mean by dilated coronary sinus. One has to deal properly if
so the patient had a dilated coronary sinus, which is like coronary sinus we see in normally all our views, madam.
So
when you
this is
see the posterior views.
donor's heart, no? Or
sorry, no, this is the recipient.
Recipient heart. Okay.
Yeah, so when recipient has a anomalous venous drainage, then strategies have to be made by the surgeon
Okay,
to
okay,
obviously ensure a good bypass, like we have for normally, madam. Same thing.
So
But in
left
this
side,
case,
left SVC you meant to say.
yes,
Yeah,
yes.
okay, okay. I got it. Beautiful. And do you I mean, just like that, practice this strain pattern on right side?
No, madam.
No.
But Deepak is getting behind us to do a lot of
Yes,
LS
yes.
trains and such
Yes,
for
yes, yes.
thing. But when we'll not my cup of tea. And I also at the end I would like to thank Amish Jaspara, my colleague in in the cardiac team, the transplant team, with whose help I have managed to do this talk. He is our main TE person. Also, like we have TE enthusiasts and we have TE experts. So he is a TE expert for us.
Mhm.
Thank you, thank you. I think regarding the EF, because of the complex nature of the shape of the RV EF by 2D is not considered as a good parameter. But when you're using 3D, I think that is corresponds to the MRI derived values, and it correlates well with the actual situation. So if you have 3D, you can always use the EF. But in 2D, we have the TAPSA and the FAC, and to some extent TDI, as you said, S prime. And also, if you have facilities, spectral tracking of the 3D also is a good parameter to go by when you're talking about the RV function in these patients. I think we have just come to the time limit. Is there any other question anybody wants to ask quickly before we close? I think it's time to.
No, sir, there's no more questions, sir.
Yeah, yeah, yeah.
Thank you.
Thank you for that. And I would like to thank both Vijay as well as Chintan for taking us through
Thank you very
this
much.
subject of echocardiography in heart transplantation. Very well done. Initially, Vijay started with surgical technique or the two techniques and went on to the details of role of echocardiography, pre-bypass, post-bypass, etc. Thank you so much. And I would like to thank all the participants and Sanjeevani Namdar for our expert comments. And we would see you next Sunday.
Thank you, sir. Thank you very much.
Before that, I think Rituparna has to put up a video regarding the workshop.
Sure, sir. So with all your permissions, sir, I'm sharing my screen.
Yes. Thank you very much. Enjoy your Sunday. Good luck.
Thank you very much, sir. Good
Thank
day.
you so much. Thank you.
Thank you. Thank you.
Thank you, sir. Have a good Sunday. Thank you.
So thank you all for sharing your valuable insights. So with all your permission, then we are signing off for today. Looking forward to host you again very soon. Goodbye. Take care.